Hi, everyone. Thank you for making it to this ethics committee meeting. If we can all just go around and introduce ourselves. My name is Angela.
I'm Denise.
I'm Kirsten.
I'm Tammy. I'm a nurse.
All right. Thank you, everyone, for being here. I've been brought a couple of cases to review with you all, and the first one I want to discuss concerns Patricia, who is a 51-year-old woman who was admitted 5 months ago with a life-threatening urinary tract infection. And since then, she has required permanent dialysis and may need permanent TPN for her gastrointestinal dysmotility. There is some confusion about her surrogate decision maker, as her husband Robert is diagnosed with recurrent schizophrenia. So we are tasked with coming up with some recommendations concerning whether or not it is appropriate to continue chronic high-tech support for this cognitively impaired woman and who her appropriate surrogate is in this situation. So does anyone want to volunteer to give a more complete overview of the medical facts of this case?
So 51-year-old female, pre-existing mild developmental delay, dependent personality, diabetes, failing vision, and poor kidney function due to the diabetes. Like mentioned before, admitted 5 months ago with life-threatening UTI, currently on hemodialysis. She has a and feeding tube. And she has current limit of treatment orders.
Great. Did anyone have any other medical facts that they wanted to add? Okay, I think that about covers it. So does somebody want to summarize any patient or physician preferences that have been stated already?
I can do that. She has indicated in the past that she was terrified of dialysis, but according to her caseworker, she easily accommodates new changes. Robert, her husband, has agreed to a limitation of treatment in the case that something were to go wrong during treatment, so no resuscitation and no reattachment to the ventilator. Because he felt that she would not want those therapies if her condition were to worsen. Her explicit thoughts on continuing hemodialysis is not really known, but she is able to communicate, though not verbally, very well. And her father is also in the picture as a potential decision maker in this case.
It says that she's on like long-term TPN, and that just puzzles me because that seems like it's a short-term thing. It's really difficult for people to live on that and on a long-term basis. So often they will get sick. I'm just a little bit surprised that the physicians aren't looking at maybe suggesting a palliative care plan for her when you're already talking about trachs and vents and TPN. But if this is what her family wants in terms of considering keeping her on this kind of level of support, I guess it's our responsibility to evaluate that.
Great. That's a really good point. Do you want to kind of transition that into other benefits or burdens of the continued treatment that she's on currently?
Well, I think her mental state is something that is a bit of a challenge, and as we've come to learn, a lot of times when people are in a better place, they say they don't want this and they don't want that, but when it comes down to it, they accommodate to it. And it looks like she's had a history of sort of adapting to things and accommodating to her illness, and so, but all these are things that any one of the things that are going wrong with her could really cause her to take a significant deterioration really fast. So even if we agree to keep her on any of these things, it sounds like it would be a good time to try to speak to whatever degree we can communicate with her and talk to her surrogates about some sort of what happens next plan.
I agree. Are there any other benefits and burdens that we want to discuss with this particular case before we move into maybe some of the contextual features?
Yeah, I just want to add, so the benefits obviously would be that it would prolong survival, and she said that she's not uncomfortable. So there is the ability to adapt, as Tammy said. Also, I'm not sure which kind of hemodialysis she's on, but if it's a venous catheter, which it seems like she's had several surgical interventions for catheter placement, then there's a possibility of infection, which might add to a burden, to be one of the burdens. And then if it's an AV graft, there is minor surgery involved, which could lead to problems with access to blood vessels, and infection from blockage from clotting. So those are some of the more serious things to think about when a patient undergoes hemodialysis, which she's been doing for some time already without, it seems like, without any of those complications.
And her TPN is also, that's an IV medication. So I'm curious about her IV access that they're using. And if she needs that, that's like a constant drip. So I'm curious about her venous access. That's got to be a challenge at this point in time if she's been this sick. She was admitted 5 months ago with life-threatening urinary tract infection. So I'm really puzzled as to how they've been able to maintain venous access this long.
Okay, so maybe it's a good time to transition into some of the contextual features if we have concerns about maybe a surrogate decision maker. Does someone want to summarize some of the people in her life maybe that could be an option for that?
Well, her parents live far away, and they have for the last 5 years, and her mother's disabled. And so they really aren't to be much help to her husband, who has the schizophrenia.
Mm-hmm.
But
So
she, yeah. Go ahead.
Yeah. So with Robert, I think it's just important for us to make the point that even though he has schizophrenia, that doesn't mean he doesn't have decision-making capacity. The reason the text anyway states that the father had that role when she was initially admitted was because he was just so distraught. It says when she was admitted, he was distressed and deferred treatment decisions to her father. So it's possible now 5 months, into this illness episode, that he's in a better place perhaps to be her surrogate. I mean, we don't know that, and that would be something that needs to be explored. But there is her husband, there's her parents, as Tammy mentioned. Apparently, even though there's that physical distance, her father must have somehow been accessible, obviously probably via phone. The text gives the implication that the mother can't be left alone because she's disabled and is cared for at home by her husband. But it certainly seems that the father can be available remotely to help, with any decision making, if it's felt that he would be a more appropriate surrogate, which was the case when she was first admitted, but we're now 5 months down the road.
Well, you make a good point. Just because a person's had mental illness at some point doesn't mean that they lose all rights to make decisions in the future. So that's a good point.
Right. And then it's dynamic. So initially when she was admitted, he was distraught, but maybe now he isn't. And then there's this wonderful woman, Georgina, 13 years, that's a long time. And so I think that's a wonderful thing. And then she also has had a primary care physician, and it seems as if they're all sort of saying the same thing. Again, in the text, the primary care reports the patient had previously been terrified of dialysis, but she easily accommodates. Georgina, mentions that the patient would not mind a dependent existence as long as she was comfortable and aware of her surroundings. So
it sounds like that person really knows her, and we can trust that point of view.
And it seems like she has a network of people who've really known her for a long time and kind of understand her preferences. So maybe kind of a shared decision-making model could work if all these parties are in continuous communication with each other and on the same page.
Yeah, I definitely think that there's enough time to gain a good understanding of the patient's preferences, having a discussion with all these important people in her life, for sure. So does anyone have any recommendations about if it's appropriate to continue this care, Does anyone have any thoughts on that aspect of this case?
Can I just say, I think it is appropriate if that's what she's wanting and her surrogate is wanting, then it's appropriate. I'm a little bit confused on why they have the question of who is her appropriate surrogate, because they're not, in the information that they give, they're not really saying any concerns that they currently have with the husband. Be kind of the default person. So, I mean, as long as he's, taking his medications and doing fine, I don't know where their concern is right now. It doesn't say, and it doesn't say who called the ethics consult. So I don't know.
That's a good point.
It may just be they're trying to check in again. I mean, if his ability to cope is dynamic,
Yeah.
it may just be at this point in the decision making with all concerned parties present, or to get everyone present to sort of feel comfortable about who that would be, and how are we even going to continue to check in with the husband, because her status will probably continue to be dynamic. So if he's okay today and then she has a bad day and he gets a little flustered, then
Good point.
again, I think it's a dynamic process is what I'm interpreting this to be, but it certainly seems as if her husband might be at that point now. Although I was curious even about the DNR, DNI, or well, she's already intubated, well, she's trached, but yes. But the limitation of treatment, no resuscitation and no reattachment to the vent. Oh, so she's off the vent. That's right, they weaned her. She's weaned and just has a trach. I would, in a meeting with them, I would just want to probe why he thinks she would want limitation of treatment, given the aggressive treatment that she's already had if she decompensates, because we don't actually have a written document or anything from her. So
It says the husband agreed to a limitation of treatment, no resuscitation, because he felt she would not want these aggressive therapies if she should worsen. So this is a plan for the future if things get worse. I guess the question is, are we comfortable with where we are right now?
I understand it's for the future, but I guess I would just probe that even further, because to me, she's already had 5 months of aggressive treatment. So if she worsens again, then I just want to understand why he thinks she wouldn't want anything done again, for example, to be re-intubated, when obviously the decision to intubate 5 months ago was made. Do you see what I'm saying? So just in terms of our recommendations with the limitation of treatment, I would just want to explore that further, in addition to the question of what are we doing right now? I'm not trying to make this complicated. Hopefully I said that in a way that was understandable.
No, I agree that we should continue to discuss the goals of the current treatment and then really encourage them to have a plan for if her condition deteriorates.
Right.
All right, does anyone have any last minute thoughts on this case or anything they want to add? It sounds
Are we
like
going to
we're
give recommendations to the team then?
Yeah, do you have any?
I would suggest that we ask case management to make sure that they touch base with each of these different people, and to make sure that we're all communicating clearly amongst them, because they're all in 3 different places, and double check that Georgina and the parents and Robert are kind of all understanding where we are, because with Georgina's insight into it, that she believes that that Patricia wants to continue with therapy as things are right now, and then have everybody just double check with him that we are okay with things staying the way they are now, continuing therapy, and then revisiting that limitation of treatment plan like Denise suggested.
I mean, I think we could just call a conference, have dad on the phone, husband come in. I think Georgina's probably local, but if not, she can join on the phone and just have a conference and discuss what we've all been saying.
In my research, I came across information on time-limited trials being helpful to patients. I don't know if it's too late for this, but patients and their surrogates found time-limited trials to be a positive thing when dealing with this kind of uncertainty. So I think that might be something to think about with these types of cases, because it kind of has a built-in process for communication and getting assent from the patient, as well as kind of continuously assessing how the patient is doing throughout the dialysis treatments. Something to think about probably for the future. I'm not sure if that would apply in this specific case.
Yeah, no, it's a good suggestion, especially when things get sometimes contentious. But yeah.
Okay, I think that we're all on a similar page about our recommendations moving forward, unless anyone has anything else to add.
I'm good.
Okay, great. Then I think that we'll write this up as a summary about our recommendation to continue treatment and maybe encourage that group conference to make a plan going forward. All right, and then we were approached about a second case that we'd like to discuss today, and this is about a 78-year-old patient named Mildred who has already been on dialysis for 4 years. This patient has been strongly resisting coming to dialysis, saying how uncomfortable it is. The medical staff and members of her family are concerned with Mildred's behavior during her dialysis sessions and would like for us to come to a conclusion on whether or not it is ethically permissible to restrain or even sedate her in order for her to continue with her chronic dialysis. So I'd like to begin this case by going over a more detailed overview of the medical facts. Does somebody want to jump in and give that summary?
I can. So she's 78, as you said, on dialysis for 4 years. Behavioral symptoms, poor memory, confusion, and diagnosed with dementia 3 years ago. She's been stabilized on a mood stabilizer and a sedative. But it seems that during dialysis is when she behaviorally struggles, shall we say. And in reaching out to her son and her daughter-in-law, they think at home that, you know, she has a life that she enjoys. It's just getting her through the dialysis is the challenge.
That's great. Thank you for that summary. Does anyone have any other medical facts that they want to add?
Well, if she is requiring one-on-one supervision during her dialysis and she is touching sterile catheters and pulling dressings and things like that, on some level, she's actually a bit of a danger to herself. And dialysis is not, in dialysis centers, is not considered a one-on-one thing. They usually can set up your dialysis, walk away, and then take care of somebody else. So her intensity of care is more than normal. And so I can see why that's problematic for the people that are taking care of her and they're trying to figure out a solution to that.
That's a great point. I think that's definitely one of the biggest considerations in this case. In terms of patient and physician preferences, of course, the medical staff have raised those concerns about her quality of safety, and they have made suggestions such as having family members come in, which takes a little bit of strain off of the medical staff. They've also maybe recommended increasing sedation or even trying physical restraints. Does somebody want to kind of go through the benefits and burdens maybe of the treatment plan that she's currently on, or maybe benefits and burdens on going towards a more sedative route?
Well, restraints are, they used to be used on older, confused people so much more in the past, but to do really considered a really severe intervention at this stage. And so, and it will probably only cause her more confusion. If she's confused and argumentative, if you tie her down, it's probably going to be worse. And so I'm curious as to for the sedation option, I'm wondering if her family is aware of any medications that have been helpful or useful with her in the past that she responds well to. People's response to sedation drugs are kind of idiosyncratic, you know. So I wonder if she has received any medication in the past that they have found helpful or useful for her.
That's a great point. I do have noted that her confusion has worsened and that maybe some of the medication she's on has no longer been improving with that medication. But I'm not sure how that relates to her sedative.
I mean,
Maybe there's things they haven't. Go ahead.
no.
I'm just
Okay.
wondering if they've tried a bunch of different things. Like, which things have they tried? There's a number of different sedatives out there in the world that we might consider. So that's kind of where my brain is.
A potential challenge with a sedative, of course, that's a very vague term. It can cover a number of different medications, but we truly wouldn't want anything that I think sedates during dialysis, because a lot of those can also drop blood pressure, which is already a challenge in dialysis because so much volume is being taken off. When we're talking benefits and burdens. So they would need to be very thoughtful about whichever drug they try. Because as Tammy also mentioned, dialysis is not a one-on-one. And so, if someone is getting too sedate where they're then losing their ability to oxygenate or their airway, I mean, that can, or drop their blood, dropping their blood pressure, they would note because they serially monitor that during dialysis. But it could get tricky. And then, as Tammy also mentioned, with the physical restraints, it's sort of not fashionable anymore. It's likely to make things worse. And a lot of times when you physically restrain someone, you have to be prepared to chemically restrain them, because most people, if they need physical restraints, they're fighting. And so they're not going to stop fighting just because you put them in restraints. And so we get into a very challenging situation.
Can I also just add to a concern with the restraints or the chemical sedation is that, it's not even like we're talking about a one-time thing. This is like multiple times every week. And so that's a lot of restraining on a person. And so that kind of concerns me that they would have to be doing this week after week after week.
Yeah, no, that's an excellent point, especially given how frail elderly people are. She'd probably be so bruised and.
Yeah, and I think it's important that we remember that her quality of life should not just be judged on how she's acting in response to this treatment. So does anyone want to kind of review some of the contextual features, maybe her life outside of the hospital? Does anyone have anything to add about that?
I will. So at home, her family says, that she's got caregivers that are around the clock with her, and that she has a really good quality of life. When she's at home, she's kind of, gets to have her daily routine and have things that she looks forward to in her day, that's calm and enjoying life. She doesn't really get agitated except for when she's at the dialysis center.
All right, so in discussion toward coming up with an answer towards this question, is it ethically permissible for maybe to sedate this patient in order to continue her dialysis? Does anyone have any initial thoughts after going through those 4 boxes that they want to share?
Well, when I first read this, I kind of assumed that she was receiving dialysis at home, and I actually had to reread it to clarify that that's not the case. But that's an option for people. And I found in my research that people who do that in their own home do it more frequently and for shorter periods of time. So that might be something to consider. It might help with her agitated state, and it would be more on her own schedule. It would interfere less with her daily life, and she wouldn't have to miss out on other things going on in her life. I also found something that talked about brain function being affected by chronic kidney disease, which I bring up because that might be one of the reasons for her agitation. So instead of it being caused by the dialysis, it might just be caused an underlying part of the disease. So there are some efforts to reduce that and doing hemodialysis at night was one of the recommendations, and that would be easier if it was taking place at home. So those, there might be some other things to consider before restraining her or sedating her, just something to try. And since she does have round-the-clock paid staff, she's used to having people in her home. I don't know. Obviously, the cost would be something to consider, but I don't think it would be out of the question.
Yeah, and I think one of the more important things that we haven't really discussed is that she does not understand that without this dialysis that she will die. So I think that education to her and her family is also a very important first step before coming to an answer to this question.
I like this suggestion of home dialysis. That's actually, I mean, I don't know what the cost is and what all of that is, but it's a good one. I think to explain to her about the dialysis, depending on how demented she is, I'm not sure how much of that she'll understand even in the moment, much less remember to carry through, to the dialysis several times a week. I think in terms of answering the question of is it ethically permissible to sedate her, I mean, I think it could be, but I think we are probably all agree we would want to exhaust, all other options before we get to that. I'm probably having someone who's familiar to her, come and sit with her.
I wonder if her
her
family could plan their visits maybe around that time. My mother's got dementia, and she was in the hospital about 2 weeks ago. And at one point, she had pulled out her IV, and she needed a new one, and I was having a hard time getting her to allow the nurses to focus on it. And I got her singing. We started to sing really loudly. But the both of us were singing, and she was so excited about it that by the time we were done with our song, her nurse had started her new IV. So it's amazing how some of those things can really help.
Mm-hmm.
Yeah, a familiar face is huge as well. I did find it striking that I think this was where I read it, because she already has sitters, but I think I read where the family was reluctant to ask them to come in because they thought they would quit or something. Am I making that up, or was
No,
that
I think that was in the story. Yeah, it was in there.
So if they even have that recognition of how challenging she is during the dialysis and how stressful that is, I think it really can be used to say to them, if there's any way your life can allow for you to be the ones to come in and sit with her. Because you're already saying her caretakers are going to quit.
Right, yeah. Maybe they could run away when the dialysis is finished,
So yeah.
Yeah, I had those moments when I was in the hospital with my mom recently. I was there. I did the time, but when I was done, I ran out of the room.
Yeah, you wanted to quit, but you can't.
Tricky. I know, right?
Yeah, that's it with your family.
Okay. Are we ready to give recommendations to the team?
Yeah, let's give some recommendations. I think we all agree that it would be beneficial to give these other options first before jumping to sedation. And I personally don't think that restraint is a good option. But does anyone have any other recommendations that they want to summarize? Okay, maybe we can go around and then just give like a quick yes or no. If our other options don't work, if home dialysis is an option, do you guys think that it's ethically permissible to sedate this patient to continue her dialysis? Denise, I know you said yes, maybe. Did you want to just give a quick overview again?
I think sitters need to be exhausted.
Mm-hmm.
Maybe the home dialysis, all of that needs to be exhausted. But I think sedation and restraints are ethically permissible.
All right, and Jamie, what did you think? Yes or no towards the?
I agree as a last resort, and it's based on the fact that the rest of her life, she's not, her day-to-day stuff, she's not having this problem. This is just at this place. So for that one thing, for dialysis, I think it is ethically permissible as long as they've tried everything else.
Great. And Kirsten?
Yes, I would agree, based on all those things Denise and Jamie said, and also maybe finding additional ways to try to communicate the importance of this to her.
Great. And Tammy?
Yeah, I think they should try to titrate the dose to keep it as low as possible in order to just get her to a safe zone, and then let her start to come out of it, as the dialysis finishes. But yeah, I think it's ethically acceptable to sedate her reasonably.
Great. Well, thank you guys all for your participation and your comments. I will write these up and give our recommendations to the medical staff.